So now it is my pleasure to introduce our keynote speaker today, Dr. Monica Gandhi. Dr. Gandhi is a professor of medicine and associate chief in the Division of HIV, Infectious Disease, and Global Medicine here at UCSF. She is also the director for the UCSF Center for AIDS Research and the medical director of the HIV Clinic, otherwise known as Ward 86 at San Francisco General Hospital. She serves as the Associate Director of the Infectious Disease Fellowship here at UCSF. Her research focuses on HIV treatment and prevention, HIV in women, adherence measures in HIV and tuberculosis, and the interplay between COVID-19 and HIV. Dr. Gandhi served as the co-chair for the International AIDS Conference in San Francisco in 2020, and recently worked on COVID-19 mitigation and vaccine strategies. And just this year, Dr. Gandhi published a wonderful book entitled The Endemic, a Post-Pandemic Playbook. Please join me in welcoming to this Dr. Gandhi.
I didn't think anyone was going to buy that book. Well, congratulations, the 2023 graduates of the Masters in Science and Global Health. So I'm really honored to be here to deliver the commencement speech for your graduation, because I served on the inaugural faculty for this program from 2008 to 2013. I taught the communicable diseases of global health importance class. And Dr. Ziegler was an inspiration to me in my early days at UCSF. So my history and roots at UCSF have been really long. Actually, I came in 1996 for residency. And the reason that and I've been here since, and the reason I was so interested in being here had to do with global health, and it had to do with HIV. So I was 12 in 1981 when the first descriptions of these terrible opportunistic infections were occurring in young men in Miami and LA and New York and Philadelphia and Los Angeles, and young gay men mainly were being afflicted with these terrible infections. We had no idea what was going on. And it was a profound moment for me as a young person. I was growing up in a state, I grew up in Utah, that was pretty conservative, and I was really surprised sometimes that I would get judged for something that I couldn't change, which is actually the color of my skin. And it made me really surprised about all the stigmatization, the blame, and the shaming that was occurring around people getting an infectious disease, getting a sexually transmitted infection for something they couldn't change. And I was stunned by it, and I wanted to enter this field. I wanted to be in HIV since I was 12. And so I did. I kind of went first to medical at Harvard Medical School, and then I came to San Francisco for my residency, and it was really a beeline for San Francisco because we were the epicenter of the epidemic in the 80s and the 90s. And I wanted to be in a place where the disenfranchised, the stigmatized, and the poor were served. And I felt like San Francisco was a place where there was a real advocacy for HIV. I also was inspired by growing up and going to India when I was a child. And I would go to India, and I could not believe that these infectious diseases had such disparate outcomes, because infectious disease of anything that I can think of are so different in the global health setting than they are here. Just we should be get under control for many of these infectious diseases. So I was really shocked by the disparity between rich and poor. So I came here, I wanted to be here, and I was really also interested in our interaction with what we did with animals, because if you think about what happened with HIV, it's pretty clear at this point that the way that HIV entered human populations was essentially a practice called the bushmeat trade, which was slaughtering and eating primates for food. And if primates have retroviruses in them called simian immunodeficiency viruses, It was a matter of time before one would jump from the primate world into humans. And that likely happened around the turn of the 20th century, actually in the 1900s. And so why was 1981 when we first saw these terrible reports of these terrible infections? Because it was quiescent, it was pretty quiet, and it was in West Africa, where cities were pretty far apart and cities were small. And it was actually the disruption that occurred from colonialism and from the sex trade and from setting up trades and from movement here and there and from growth of cities that led to spread in West Africa. And then the infection, and this talks about disparities, had to come over from West Africa to East Africa to really set up the condition, to have the conditions for spread set up, because there was low status of women, there were low rates of circumcision among men, there were truck drivers, there were people going here and there, and all of that set up the conditions such that by 1986, 85% of sex workers in Nairobi, Kenya were infected with HIV. And by that time, then went to sub-Saharan Africa, spread, and then we had the world map in 1985 really being in East and Southern Africa. And then if you go along in time, by 1995, spread around the planet, 2005 with the breakdown of the former Soviet Union, spread in former areas of the Soviet Union. And now we're living where we are today with HIV. 39 million people living with HIV worldwide, more than any other time in history. 40.4 million people have died from HIV since the beginning of the epidemic. 1.3 million new infections last year. We thought we'd be at a much better place than we are with HIV. There were setbacks during the COVID response. And every 2 minutes right now, and this speaks to disparities, and this speaks to all of the social factors that lead to HIV infection, every 2 minutes an adolescent girl or young woman is infected with HIV in sub-Saharan Africa. So it's a disease of disparities. It's a disease that's not over. And I think it's really important that you're all going into global health. I'm talking about one infection, but it's an important one because it speaks to a lot of what happens that leads to disparities in infectious diseases. So here in San Francisco, HIV was a part of the city's ethos. And in 1984, the San Francisco Chronicle had a single headline, and it was called The Year of the Plague. And that same year, men were marching on the federal building saying, we're fighting for our lives. And it was this advocacy, it was this involvement of community and clinicians and researchers and everyone working together, maybe sometimes to wrap Jesse Helms' house in a big condom, whatever they were doing, whatever was happening in terms of advocacy, researchers, clinicians, and patients and people living with HIV and people who cared about people with HIV, we were all doing it together. And that sort of activism, that combined activism, is what changed the face of HIV and led to these advent of these highly active antiretroviral therapies. I came to UCSF at the beginning of 1996. I was an intern at San Francisco General, and a full-on 50% of our patients were AIDS patients, and they were dying. And by the end of the year, with the advent of these highly active antiretroviral therapies, we were literally watching people rise from the dead. It was incredible to see the advancements in what biomedical advances do for infectious disease. And that's going to come up when I talk about COVID-19. So the Ward 86 HIV clinic at San Francisco General Hospital is the public health hospital for the city. It was founded in January of 1983, 18 months after the first descriptions of AIDS in this country. And it is a model of care, but it's a model of care that I think led to other models of care. Our model of care was if you were dying and there was nothing that you could do to help someone, we would not want people to go here and there for their medical care. And everything was on site. Case management, social work, everything was on site. And it was kind of this one-stop shopping model of care. And it was important because it inspired a program that in August of 1990 was started called the Ryan White Care Program. And Eric Gooseby, who was going to be your graduation speaker, and I'm a very poor second for him, he was the first executive director of the Ryan White Care Program. And then after that, PEPFAR formed under President Bush in late 2003. both of these are bipartisan initiatives. And PEPFAR is also a disease-specific program with AIDS, but it's bringing in all of these other infection management, and everything is trying to do one stop. And Eric Gooseby was the PEPFAR director under President Obama. So you can see that these threads of what started from Ward 86 have gone into national and international management programs for infectious diseases. So I now want to tell you a little bit about my work in COVID-19, and that, yes, I did publish this book, but no one but my mother and you have actually purchased it, because I think people are very tired of COVID. But I think I can't actually tell you about this book and why I wrote it and why I was very involved with COVID-19, unless I tell you something personal, which is 3 months after my second child was born. My husband got ill from cancer, and he died in November of 2019. And that was 3 months before the COVID pandemic. And what happened during COVID is I was told that we had to stay away from everyone else, and the bubble had been burst, and we had lost a big part of our family. I live with my 2 sons, and it gave me an idea about how to work on COVID-19 using a harm reduction approach. And what do I mean by harm reduction? Harm reduction actually was started from HIV. The idea of harm is reduction in any response, whether it's addiction, whether it's HIV, is that you do everything in your power to control a pathogen, but you also minimize the harm of interventions that aren't working. And so a lot of the work that I did during COVID was using this kind of harm reduction lens, that and the idea that people do want to come back together, and they do want to have celebrations, and they do want to say that they're graduating, and they want to be together, and it's a part of ourselves. It's part of being a human. So I will tell you about kind of the aspects of the book, because they speak to, I think, what I'm going to see you all do when you go forth. But chapter 1 is really about HIV as a prophet and teacher for COVID-19. I do think we could have harnessed more lessons from HIV in our management of COVID-19. And what I mean by that is we celebrated biomedical advances in HIV. When we got these antiretroviral therapies, we were truly celebrating on the streets. It was amazing. And it was also saying that unlocks the key to normal life. In fact, the International AIDS meeting has just ended in Brisbane, and there were not protests, but celebrations about the idea of undetectable equals untransmittable, that if you're on therapy and you don't have a detectable viral load, you can't pass it on. Celebrating biomedical advances is a huge part of fighting a pandemic. And I think we could have celebrated the vaccines and the therapeutics for for COVID-19 even more than we did. Europe celebrated them. They said, get the vaccine, go back to normal, life is great. And we had along partisan lines a little bit of a take the vaccine, but nothing changes in your life. We're going to still mask and socially distance. It was really confusing, and it was political. So the other thing that I got from HIV, that we all got from HIV, that we could have applied more to COVID-19 is resources before restrictions. It was actually the poor that suffered from both COVID-19 and also the response to COVID-19, like closed public schools as opposed to private schools, like the idea that people could stay, but who were delivering food to them. And that was people who are low income. The same thing happened in 1851 in the cholera epidemic in London. People were very safe if they were in their houses, if they were rich, but who was delivering food and water? It was the poor. So how do we give resources to people who are low income to keep them safe, as well as those who are high income? Chapter 2 of this book goes over history, epidemiology of COVID-19, including the surprising fact that children were much less at risk for severe COVID than adults, and that isn't true of measles and mumps and rubella, and it has to do with the pathophysiology, and how our vaccination rates in this country, as the high income country that did the worst, were marred by politics. And when we went through the Delta surge, we didn't have the vaccination rates in some of our states that we should have. Chapter 3 goes over the fact that it is a non-eradicable virus. Some of you will be working on COVID-19 in the future. Our lives are changed forever. This is a new infection that's entered our population. And going forward, when we manage it, we have to think about boosters for people who are older, boosters for people who are immunosuppressed, and we have to always work on antivirals. And those are the therapeutic advances that we need to celebrate and work on harder for other RNA viruses. Chapter 4 goes over the duty of public health, and I think this speaks to a lot of global health and what's our duty. And there are 10 points in that duty. What is our duty to serve others? And I won't go over them, but I'll tell you that the first one is resources before restrictions. I think, again, resources for those who couldn't protect themselves is what we needed to do more of. Do more for those who need more. The affluent will actually be able to take care of themselves, but it is those like my patient at Ward 86, for which I serve as medical director, who had no resources during the pandemic after they lost their job, after they lost their insurance. They didn't have anything to help them. The third is meeting people where they are. That's harm reduction. You can tell people how to stay safe. You can tell people about masks and distancing and ventilation, but at a certain point, it is a person's ability to decide if they want to have a funeral for their family member and go to church. The second is public health must be driven by data. And I think there was a huge infodemic, as the World Health Organization described. We would get papers and they weren't data driven, and sometimes they weren't well reviewed. And we had 87,000 papers during COVID-19 in the first year, when we've had 87,000 papers of all of the HIV epidemic. So there was too much information and sometimes it wasn't right. Debate and dialogue. I think there's different ways to manage a pandemic, and we have to be able to listen to each other. That's part of science. And duty and sacrifice. I think people who treated people living with HIV at the beginning of the pandemic, I admire them. I admire people who started Ward 86, and I admire people who stay with it and work with people who have infections, because that's our duty and that's our sacrifice in being in public health. Speaking truth to power. Interventions without judgment, tell people how to stay safe, but we can't judge, we can't blame, we can't stigmatize, we can't say, how did you get COVID? And public health does not know borders. And I'll end with that part. Chapter 5 is actually about school closures and I think the harms that they caused. And then chapter 6 is about global equity. And I'll end with this part because this is what you're all working on. If we think about the history of antiretroviral access, it was really poignant. So we had these amazing antiretrovirals I told you about, and everything changed for people in the US and Europe in 1996. And by 2000, still weren't being distributed to sub-Saharan Africa. And in fact, the International AIDS meeting in Durban was essentially one prolonged protest of, we have the medications and South Africa doesn't. And it was shocking and it was disturbing and it was responded to. And how was it responded to? India and other pharmaceutical companies, some in Brazil, decided to make antiretrovirals for less than $1 a day and sell them to the places where the infection was at its highest prevalence. And that was sub-Saharan Africa. And not only did, of course, South Africa purchase antiretrovirals for their population, but soon thereafter, the pharmaceutical companies actually sued South Africa and said, you're purchasing them for too cheap. And so what happened? We took to the streets. And I mean, we took to the streets. Doctors, clinicians, researchers, public health practitioners, patients, people who were living with HIV, and said, are you kidding? Of course, people need antiretroviral access, and this was a way to get around it. And the pharmaceutical companies dropped their suit. And so it's advocacy and it's activism. And so what happened with COVID-19? With the vaccines? So the trials were happening with the COVID vaccines starting actually in the summer of 2020. It was amazing because March 11th, 2020 was the declaration of the global pandemic by the World Health Organization. And by the summer, there were already ongoing trials of highly effective vaccines. And so in October of 2020, before the trial results were out, India and South Africa went to the World Trade Organization and they said, we have done well so far with COVID, but what if there's a variant, I don't know, called Delta or something, that comes and hurts our populations? What if something happens? We need access to the vaccines. Please invoke what's called the TRIPS waiver through the World Trade Organization and allow these vaccines to be made off patent in lower income countries, in India, in Brazil, in other places, South Africa, to distribute to the world. And the World Health Organization said no. And then Biden got a letter when he was elected from the pharmaceutical companies and said, you know, that thing that India and South Africa asked for? No, 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 don't do that. And it was publicly made available, and we didn't push hard enough for global vaccine equity, and we didn't give out the vaccines. And yes, India went through a terrible Delta variant surge in March of 2021, and we didn't learn from the antiretroviral access story that in the middle of a global health emergency that we should have had widespread access to the vaccines. And now we're in a position that when finally vaccines were made widely available, there's reduction in vaccine confidence. There's vaccine hesitancy, and that's what Dr. Sepulveda described. This is where we are now. We are in a place where there is lower trust in public health, and there is lower trust in vaccines, and it is your work to combat this because a lot went wrong during the pandemic. And then this last chapter is sort of a 10-point pandemic playbook for the future. And it's 10 points, and I think that they all make sense, and you're going to work on every single one of them. But the first one is accelerate vaccines. What I mean is no pandemic as we are in the phase of global warming and how we interact with animals, which isn't good. We are in a phase of pandemic potential, and we need to know that we can develop vaccines very quickly. It was amazing what happened during COVID. It was miraculous. But because of that, we had to accelerate vaccinations and accelerate global equity to those vaccinations. The second is I think we had to ease restrictions. If you have vaccines, that's when you can tell people that life goes back to normal, or at least that's what they did in Europe, and that did increase vaccination rates. The third is I think we need to use education and more harm reduction principles, a little bit less coercion, because it didn't work and it backfired in the pandemic response. I think we need to use the outside. Outside are safe spaces. If there's a respiratory virus pandemic, don't close the outside, encourage the outside. And a lot of this book is about school being a sacred place for children, and as much as possible, working on children getting food and learning and what they need at school. I think that if something doesn't work, like deep cleaning, stop deep cleaning, because I think that things that are ineffective prevention measures can decrease trust in public health. I do think that we have to work on antivirals for any non-eradicable pathogen. Smallpox is eradicable. COVID-19 wasn't. There are about 35 animals that contain COVID. That's the simple reason that we can't eradicate COVID. So work on RNA viruses, therapeutics. And then what's the last phase of the pandemic playbook? Where we are next, where we are now. It's to prepare. It is to build trust in public health. It is to combat anti-science forces. It is to celebrate biomedical advances. And that's all of you. That's what you're going to do. You're going to go out and you're going to increase trust in public health. And I think that you're going to work to combat these disparities, and I'm really proud of you. In conclusion, the world has always struggled with disparities in vulnerable populations, such as those living in poverty and with stigma, and they're more prone to infection and poor health outcomes. Great education, like what you just received at UCSF, comes with great privilege. It is our duty as graduates of the JHS Master's Program to go out in the world to attempt to fight these disparities, combat the stigma, and carry the ideals of our rigorous scientific education forth. Graduates, I'm honored to be here with you today, and congratulations on your achievement.